KBC Channel 1, and we are glad that you are still with us. Time now for Health Tuesday, and today we are looking at immunization, financing and policy. Now, for decades, Kenya's immunization program has been quietly saving millions of lives, and it was largely backed by donor funding. However, that safety net seems to be shrinking, because by 2029, Kenya will largely be on its own. So the question here is no longer about whether vaccines work. It's more about, can we afford to keep delivering them? Are we prepared for the post-donor era, or are we staring at a slow and silent reversal progress? That is a conversation, or the basis of our conversation today, which regards immunization, financing and policy. And I'm having that conversation with Alan Miheso, who is a programs officer at Health NGOs Network. Karibu sana.
Thank you for having me.
How are you doing this morning?
Doing very well. Thank
yes. You. You know, we have seen recently that Kenyan lawmakers are pushing for stronger local funding for immunization as the country prepares to transition from the support by Gavi, the Vaccine Alliance, by 2029. So what does transitioning from donor support actually mean in real financial terms for Kenya today?
Okay, thank you. The first, maybe I give a background.
Yes.
The reason why we are transitioning is because Kenya moved from a low-income country to a low-medium-income country in 2014, and that is because of the classification, the World Bank classification of the economic rebase of countries. And one of the reasons that we had to transition is because of the economic prosperity that the country was witnessing at the moment. And therefore, the transition from low-income country to low-middle-income country comes with the challenges such as now donor transition. So Gavi's policy does not allow it to continue supporting immunization services in countries that are under the category of low-middle-income countries. And therefore, in 2029, Kenya should be ready to take up the full immunization cost at the moment.
What does it mean for the country when we reach at that point? What will it mean?
That will mean we need to be very creative on how we are raising revenues and be deliberate on how we are going to allocate finances towards immunization.
From where you stand, why is it that we have taken immunization as immunization financing as something that needs support, especially on foreign support?
Maybe the way it was transitioned or captured at the initial planning stage, Gavi came in as a savior, especially on addressing issues of children not having fully immunized. They are called zero-dose children, others are half-immunized children. So the zero-dose are the ones that have not received any vaccination. So the donor came in to salvage us from the high rate of children that had not gotten vaccination.
Yes.
And the reason why the donor came in mostly is when children miss vaccines, they are prone to chronic diseases such as polio. There are those who die from tuberculosis if they do not get the diphtheria vaccine. So there are different dynamics around it. And also looking at hard-to-reach areas, looking at counties that are far-end like Wajir, Mandera, where healthcare facilities are not also that close to the community. So it came in as a savior, especially to those kind of communities where children also are missing out on routine vaccination. So the donor came in as a savior, but then now having strengthened our systems, and also with the devolution coming in, counties now having to taking up service delivery of immunization services, I think we are in a better trajectory to continue now moving on with sustaining our own immunization need.
And from where you sit, are we having a honest national conversation about the implications of transitioning away from donor support, or are we downplaying it? Very true.
We would say with this current regime, especially with the new CS coming into the docket of the health docket, he has been very deliberate about immunization financing. If you look at the MOH statement on April 24th,
yes,
they had a meeting with Gavi, some representatives of Gavi, and you could see that the Ministry of Health has deliberately allocated Kenya shillings 4.6 billion towards vaccine procurement, and then 2.6 billion, an extra of 2.6 billion towards the co-financing.
yes.
Maybe just to give a background on co-financing as well is Kenya has an agreement with Gavi,
yes,
where Kenya pays a share of the co-financing and then Gavi pays the balance. So it is Kenya to pay the co-financing, and then we pay to UNICEF, because UNICEF is the standard body that is used to procure vaccines because of quality and also reduced prices. So when Kenya pays the co-financing money to UNICEF, UNICEF tells Gavi Kenya has paid its co-financing share, and then now Gavi pays the balance. So the current administration allowed it for being very deliberate, and also for increasing the immunization budget. All along, for the last like 3 financial years, our immunization budget has always been 4.6 billion, but at the moment it's at 7.2. So you can see there is some traction towards allocating more resources towards immunization and sustainability.
So in a way, we have been underfunding immunization to some extent.
Yeah. Just because in the background we knew there is a percentage the donor is giving us.
And now that now that is changing. Now, you know, from your engagement across the region, how can you, what can you say? Is Kenya behind or ahead when you compare it to other transitioning countries when it comes to immunization financing?
I would say we are a bit lagging behind, and the reason is because we do not have a transition plan at the moment. Other countries, the likes of Zambia and Nigeria, have an immunization transition plan. They already know what is the costed plan when the donor leaves, how much is their immunization need, what is the approximate age, approximate population of children to be born by then, and what will it cost the nation. So it's something that at the moment the country is still not yet there, but I hope with continuous engagement and with such discussions we might get the attention of policymakers to start looking at how are we going to develop a transition plan, because we are 3 years shy of the Gavi transition.
Because I'm asking that because we need immunization as a preventive care, preventive health care, because that is one area that struggles to attract political financing compared to curative services. And as you have said, Kenya has allocated 2.6 billion for Gavi co-financing, which of course looks very committed, and also it's geared towards getting ready, towards taking responsibility when it comes to immunization financing and policy in the country. And given that we are moving ahead in that direction, my question to you would be, why does preventive healthcare like immunization struggle to attract and sustain political financing compared to curative services?
I would say it is the orientation of the political class and also what Kenyans expect from politicians. I would go with immunization, allow me to call it a software, because it's not seen.
Yes.
Immunization, vaccination, nutrition are maybe software programs that might not attract a lot of political goodwill, but they are very important. As opposed now to the hardware where a politician will build a healthcare facility, even if it is not resourced, but it gives them a lot of political mileage on the front that I build this healthcare facility. So it's an issue of just trying to bring in community, the leaders, and also the media to start changing the orientation, our thinking around healthcare investments, especially on these that might not be seen, but they are very effective.
Yeah. You know, the Kenya 2010 Constitution, decentralized health delivery. In other words, it devolved health services to the county level in a bit to enhance responsiveness.
Okay.
But in practice, has it fractured immunization in terms of financing?
Not really. The initial organization on immunization procurement was to be done at the counties, but then because of quality and also reducing the expenses that go into vaccine procurement, the national government took up the responsibility of procuring the vaccines, and that is why we are talking of the Gavi co-financing, because now the national government takes care of the procurement of the vaccines at the national level, bring the vaccines to the regional stores, and then now the counties can pick the vaccine from the regional store. However, we have to agree that there are funding gaps at the county, because immunization is ramped up in reproductive, maternal, newborn child health.
Yes.
So it is a component of the RAMCA strategy, especially when it comes to financing. So you will see more resources are allocated to RAMCA, and then now the sub-programs, there is immunization, nutrition, all that. So they get a very small percentage at the county. And then now you see the county bears the burden of service delivery. So they have to take the vaccines from the regional store and distribute to the lowest level facility in the community. So the funding at the county is a bit low because now it also comes with resource, human resource, it comes with hard stock, syringes, all that. So the counties also need to start taking up the challenge of increasing their immunization budgets for those that have, and for those that do not have an immunization budget, to start thinking of introducing an immunization budget, so that by the time also the national government is transitioning from Gavi support, the counties are able also to sustain the small bits that they have done.
Yeah, because this is serious, because counties are charged with delivering the last mile immunization to the people. But from what you've seen, who should be held responsible when it comes to allocating enough immunization finance to ensure that there is an undeterred last mile immunization delivery?
This is a collective responsibility. I will talk of the executive, especially the county treasury and the Ministry of Health, and the Department of Health at the county. They should be very deliberate in allocating money towards immunization services. But then also just to bring to your attention that the challenge that has been at both the two ministries, both at the national and the counties, we might allocate the money, but now the other issue becomes the disbursement. So you might find the treasuries are not releasing the money on time, and therefore the last mile delivery also vaccines becomes affected. So it should be a collaborative effort between the Ministry of Health and the Ministry of the Treasury at the county and the national level as well.
And should vaccine delivery remain devolved if counties can't consistently fund last mile logistics? Should it be left to the national government, or just?
I would think they should remain, because the counties also now, there are new other innovative funding models that are coming at the counties, like the FIF, the Facility Improvement Fund. We have the PHC fund that is also supporting healthcare facilities at the local level. So we can look at how are the facility improvement funds. Can we have a percentage, like 2% allocated towards immunization service delivery? So it's just a matter of prioritization of budgets.
You've said something about new innovative funding models. If you can talk about those.
Yeah, at the moment, the counties have the Facility Improvement Fund. It is a constitutional mandate that they should have. Now, the challenge maybe that comes in with the counties is most counties do not have regulations that are guiding the facility improvement funds on how they are to be used. But it's a good fund that can be used to improve general healthcare service at the county, not only immunization, but now it can also help in having human resource on board, buy a vehicle to do distribution of, do outreaches. Like a county like Baringo and Isiolo have been very deliberate on doing outreaches because of the pastoralists, the migrant communities in the region. So you will find the Ministry of Health use the mobile clinics, go to the villages to reach out to people and administer vaccines and all other healthcare services. So there is the Facility Improvement Fund, and in the spirit of integration with the stop work order, we decided we have to be also innovative so that we are not found in the gutters. So there is blended financing, which is now adopting the PHC fund, where several health programs can be put together and they are funded together. Like KEMSA delivering health products to local facility. The counties can facilitate KEMSA to do that and also deliver hard stock for immunization, the syringes that are needed to the county. So blended financing, facility improvement fund and PHC fund are some of the innovative models, financing models that can be adopted. Yeah.
In your observation, where does the system break down? Is it procurement, allocation, or it's a last mile delivery? Where is the breakdown?
The breakdown will become at the county. It's both allocation and release. The money can be allocated but not released. So it is on paper. Like
not implemented.
Yeah, not implemented. Like for example, a case in point, we work in Laikipia County. They have introduced an immunization budget line and allocated 1.5 million Kenya shillings towards immunization.
Yes.
But then, will the county treasury release that money on time so that it is able to support the county logistician in charge of immunization to do service delivery to the community at the lowest level? That now becomes the challenge.
It's a challenge.
Yeah.
You know, the civil society has consistently called for increased health financing. But what is the bigger issue? Is it how the current funds are being used?
Yeah, we can say it's how they're being used, but also the civil society comes from a point of understanding that Kenya is a signatory to international treaties. We have like the Abuja Declaration, which demands that we need to allocate at least 15% of our national budget towards health.
Yes.
We've not achieved that 24 years later. So
we are still lagging behind.
Yeah, we are almost at 7 or 8%.
Yeah.
The Abuja Declaration, which is 15%. So when civil society asks for increased funds towards healthcare, it comes from a point of concern and also accountability on why are we signing these international agreements, but we are not living to them. And also just to looking at the report that has come out from the Kenya National Bureau of Statistics.
Yes.
You can see there is a report that SHA paid almost 159% of what it collected. Like the claims are more than what is collected. So increasing the fund, the healthcare budget, will also help bridge the gap. In the supplementary budget that the president ascended to early in March, he mentioned that he has allocated 4 billion towards the social health authority. So you can see it is an increase in budget directly diffuses to other healthcare sectors that may be headed on a support and are not now supported by the donors. Yeah.
You know, I'm intrigued. When you look at the continental context, what do you think other countries are doing or getting it right that Kenya is not?
One, I will talk of our system of administration is devolved. So there are different centers of authority and command. And this comes in, you see President Ruto comes in with the better plan.
Yes.
At the county, the governor has his own plan. So also trying to adjust and fit into the national manifesto becomes a challenge.
So manifestos, the national and the county manifestos are not aligned.
Yeah, what the governor promised his people is not what the president has promised at the national. It creates a lot of miscommunication.
Yes.
And now you see rolling out of such programs even to the county becomes hard because the governor might not be able to adopt it or they might do it because it's from the national. Also, we face the aspect of duplication of roles. You look at what the national is doing at the in health, look at what the county is doing, it's more or less the same. So maybe we just need to align. And also there's so many funds. As a Kenyan now, these are, in my own opinion, if we had all these funds in a basket and plan for them very well, we will not be having a challenge in financing.
Consolidated in one fund.
Yeah.
So that it can go to
Yeah,
whatever
we
is...
just know we are funding HIV program from the national, and this is the budget. These are the people that are taking ARVs from our healthcare facilities. This is the number of children we estimate to vaccinate in a year, and this is the budget we've allocated towards immunization. And this is the money we've allocated towards last mile delivery. It becomes that easy, in my thinking,
yes,
as a Kenyan now.
Yeah.
Yeah.
And from where is it a policy failure, or there lacks a political incentives problem? Is it a political incentive problem or a policy failure in some way?
We have the policies. The policies exist. I would agree with you. The political incentive, the goodwill now becomes a challenge, because also now, and also the resource basket becomes smaller, especially for when it comes to counties that have migratory communities.
Yeah.
The likes of Marsabit, Wajir, Isiolo, part of it. These counties have a challenge of raising revenue, because one time this community, the guys are here, the next time they move to another location. So, and they're not engaging in any productive economic activity other than subsistence farming and just survival. So you find the resource basket for the counties become a challenge. And despite having the equalization fund, I think we need a policy on equalization fund and how it can help healthcare facilities in the country. Yeah.
And if we had, as a country, we had to prioritize one reform, what would that reform be to ensure that there is immediate improvement of immunization outcomes across the country?
Okay, one policy reform I would largely look at is increase the number of regional stores for vaccines. A case in point, we work in the county of Isiolo.
Yes.
And they get most of the regional stores in Isiolo, is in Meru, sorry. So getting the logistical support for the county to get the vaccines from Meru regional store to Isiolo is a challenge. And they are quite a distance from each other. So policy implementation when it comes to let's improve maybe if we are having a challenge with the power, we can solarize our cold chain stores to store vaccines, and also now improve outreach to lowest level in the community. Yeah.
At what point do we start making hard decisions about which vaccines to prioritize?
I think we should not have a discussion on what vaccine to prioritize, because all of them are very critical. At the moment, the government has introduced malaria vaccine, especially for Kisumu, Busia, Homa Bay counties, because of the prevalence of malaria vaccine, and Kakamega. So it has been introduced into the immunization schedule. And also we have HPV that was administered to girls between the age of 9 to 14. There were 2 doses initially, but now it has been synchronized into 1. So the conversation around which one to prioritize, I would say no. All the vaccines are critical. The only aspect that we might need to look at is have good political will, and also try to address the issues on vaccine hesitancy. Because there is a lot of misinformation and misconceptions around vaccines. You would, I'm very sure, you being in the media, you've heard about HPV. There were those misconceptions. It's used to sterilize girls. There are questions why only girls being vaccinated and not boys. So, but then the HPV is a vaccine that helps protect girls against cervical cancer.
Yeah.
Men don't have. So just the dynamics around it. Maybe now, if there is a policy which is not really a policy change, is just have good political will, have ambassadors of immunization. Let's talk about it as a life-saving measure, as a preventive health measure, other than looking at it as an emergency priority. Yeah.
You've talked about vaccine hesitancy and the misconceptions. When you look at it, is it the misconceptions or just lack of adequate information regarding vaccines?
Both. Both. When you go to some places, it's just that people don't know. And then there are places where you go and there are these just theories that come online now with the TikTok University. Social media has become another issue. there are those adverse effects. There are sometimes a child is immunized, there are those called adverse effects after immunization. Maybe there's high fever. To some extreme cases, there are deaths that are recorded. And then now when that is picked and it's taken on social media, you see people start consuming that. And it becomes like an issue also to support uptake. There was a campaign on against polio last year, if you remember, and it had a lot of challenges, especially for a county like Nairobi, where you would expect that people are exposed. So you find that there are those challenges that come with just the adverse effects that follow immunization that come with fever or that, and then there is that misconception because it's targeted. For example, HPV is targeted for young girls. Now the questioning when it comes like, why only girls? And then you see parents will retract.
Yeah. All right, and let's come to policy and implementation. Of course, sometimes in the country we do have policies, especially when it comes to immunization. But do you think there are lags? We are lagging behind in terms of implementation, and why is that?
Yeah, we lag in implementation because as much as the Constitution says you have a right to health,
yes,
what has been the practice is even if the healthcare professionals go to churches or schools to vaccinate, you will see that the parents have to give consent. So as a policy issue, it lets the parent have a say on the life of the child, whether the child is to be immunized or not. So I think we just need to have a policy reform and say maybe we were in a meeting somewhere and one of the logisticians on immunization was proposing that maybe before children are admitted to class 1 or grade 1, they should have the fully immunized schedule. They should have that card to show that they are fully immunized, so that maybe we reduce the number of zero-dose children in the country. So it's not really a policy issue. It's a policy issue, and it's also just an understanding towards the value of immunization.
When you look at funding at the county level, should funding be conditional such that it's tied to a county's performance in how it's delivering its last mile immunization to the people?
Yeah, it should be. It should be conditional because different counties have different dynamics. So there are those in highlands that might need a lot of money to access the communities in those areas. So we need to really have that budget line towards immunization and ring-fence it. Ring-fencing means you are prioritizing it as a critical budget that needs to be expensed in the first quarter of the financial year, so that the teams working in the healthcare space are able to give services without those logistical interruptions.
Let's look at leakages, and this is with regard to financing. Where in the immunization financing chain is money most susceptible to inefficiency or misuse?
At the national level, it's very rare because the budgets are tied. Like you can see, we just have 2.6 for co-financing. So we just allocate 2.6 for co-financing and pay. Maybe at the county level is when the money is released, maybe now we might have an influx of ghost workers in terms of human resource. Maybe you might have healthcare facilities reporting on having more workers, which might not be the case.
When you look at accountability, do we have weak accountability when it comes to those areas of immunization financing? Is it the bigger threat than insufficient funding? Which is which?
At the national level, it is not really an issue of accountability. With the interactions we've had as an organization with members of parliament, it was a matter of understanding.
Yes.
So once we've engaged them and they understood the value of having the money, they are always the ones that are even the first ones to tell us we've budgeted for that and we've released that money. And it's a matter of knowledge. At the county level, maybe now it's also the gap that comes in with the county members of assembly. So it just needs also to intensify education around it, and also ensuring that the accountability mechanisms are enforced. Yeah.
And when you look at access and equity to immunization, who is at risk? Who is most at risk when it comes to when immunization financing falters? Is it the system as a whole or specific population? Who is at risk?
The ones that are at risk, I would say, are those that are in hard-to-reach areas, the underserved populations. Those ones are at highly risk. And the migratory communities we are talking about, because now when even the counties go for outreach, if you found them at point A today, you go for a follow-up. The next time when you're administering, you might find some of them are not there.
Yeah.
But then the counties and the regional focal persons on immunization have a default register. So they'll just register that this child was immunized on this date, but on the follow-up didn't show up. So what the challenge that we are having is the aspect of defaulter tracing. We are not able to trace the children that have missed immunization. And therefore, some of them will just grow.
Yeah.
Some will pass out, will pass on, and then there are those who will now live with disability. A case in point is Hennet works with the Honorable Bishop Kosgei.
Yes.
I think you know him. He's an immunization champion for Hennet. He's a champion because he lives with polio. He has the lived experience of polio. So when he talks about it and you see the level of disability he has, that rings a bell on how important the vaccine should be and how important as a country, maybe intergovernmental relations, just to ensure that we have defaulter tracing for children that miss immunization, especially those in underserved regions.
Yes. Yeah. And from where you sit, as a country, should we establish a legally protected immunization fund that should never be reallocated?
Very true. I will be very happy to have that, because initially in the last 2 financial years, we've had vaccine stockouts. You've reported about it.
Yes.
And the issue was the delays in the government honoring the co-financing. And when we delay to pay the co-financing, the vaccines don't get to us. And now the expense also comes in when we get the vaccines after we've delayed to pay the co-financing. We now also start looking to borrow money from partners so that we can do a catch-up campaign. Yeah. And you see now it triples or doubles the budget.
Yeah.
So if we have a restricted fund where it is ring-fenced and we know purely this is for immunization, that will really work for the county and for the country and also for the counties.
But do you think we are bold enough as a country to restructure how immunization is financed, or we shall be just managing the decline?
There is goodwill, there is political goodwill. I have to appreciate the CS and the government for that. The issue now we have to talk about is, at the moment, what Gavi expects Kenya to be doing is Kenya pays a bigger percentage as Gavi reduces. So we should be at 70% while Gavi is paying 30%.
Yeah, because it's the other way around.
Yeah. So at the moment, we are still on the same scale where we are paying 30, Gavi paying 70. So what we just need to do is continuous engagement and lobbying so that the ministry gradually increases the budget as Gavi reduces. And because now, at the moment, the immunization funds have been ring-fenced, they have been prioritized in the budget. I think when they increased, it is easier now for the treasury also to pay it out on time. And we have vaccines on time.
Once ring-fenced in the budget, should we go to on a path that brings us to ring-fencing immunization funding in law?
Yeah, if it is possible, if we have that legal pathway, it's a good way. So that
it would go a
long way in supporting.
And in terms of structural reforms, and this we are talking from a solution point of view, do we need to rethink the national and county split in how we deliver vaccines, especially the last mile delivery of immunization?
We don't need to, because at the end of the day, it's the county, it's the people in the county. So it's the county that understands its people. And they also have that data. We have developed, supported different counties like Kisumu, Kakamega, Isiolo to develop investment cases for immunization. So we've we have those indicators of which regions have high immunization rates, which ones are lower, and which one have the lowest number of zero-dose children, the highest number of zero-dose children, those who have not been immunized. So when we have the investment cases, I think taking it now to the executive at the county, they have been able to look at how critical that information is, and they are using that information now to slowly introduce immunization budget lines, increase it, and support the logisticians at the county to deliver vaccines. So the national, I would wish that they remain with the aspect of procurement, and also now supporting social behavior change. What we've talked about, hesitancy, cultural biases about vaccines, but then the counties remain purely with the delivery, because also the community health promoters work at the counties. So, and the community health promoter being in charge of, it's 100 households, so they really know which family has a newborn, and they can easily track, which might not be the case for the national.
For the national government, actually, because they are the people on the ground. And you know, what early signs should we be watching out to indicate that immunization coverage is beginning to go down?
We look at the reports. We have the Kenya Health Demographic Survey that gives the immunization scale in the country. We have UNICEF. Last year, when UNICEF released its report, showed that the number of zero-dose in the country had increased to 133,000. And that was alluded to the vaccine stockout that we had. So just looking at the reports that come from these credible sources, the government itself, the Kenya National Bureau of Statistics, the KDHHs will show the immunization indicators, and we are able to see if we are improving or we are not.
And which is more urgent? Is it the national reform on matters to do with immunization, or it's matters to do with county accountability?
Both are important, but now county accountability becomes critical, because if they come with the information, let's say 7 counties are reporting highest number of zero-dose children, those who have not been immunized, it must ring a bell at the national, and the national will have to look at an intervention. And because there are those intergovernmental relations between the national government and the Council of Governors, the Ministry of Health, and the Deputy President being in charge of the intergovernmental relations, they can be able to chart a solution.
And finally, what do you see as the future of immunization, financing, and policy within the country?
One is to tell everyone that children don't have a voice. We are the voice of the children, so we have to speak for them. And when it comes to policy, majorly is the ring-fencing, as we've said. Let us ring-fence the immunization funds. Let us have it increased so that when the donor leaves, we don't fill the gap, like what we felt with the stop work order early last year.
Alan,
yes,
that was our time.
Thank you so much for having me.
Asante sana.
Asante.
Alan Miheso is the programs officer at Health NGOs Network, and he has been talking about the immunization financing policy right here on Good Morning Kenya.